Good evening, everyone, and welcome to the next episode of our malignancies by the AIG Hospitals. Today, we shall be covering the gynecological malignancies, most importantly, the cervical cancer. Cervical cancer is one of the most prevalent cancers among women in India. Today, it is the second largest group of cancers among women. There's been a lot of development as regards the screening, the diagnostics, and the treatment of cervical cancer. And over the course of the next 4 lectures, we will see how cervical cancer can be diagnosed early and how we screen for it, how we diagnose it, and how we treat the cancer with surgery as well as radiotherapy. There will also be a talk in between which would include part of surgery for cervix and will also concentrate on surgery for the carcinoma endometrium. So, without any ado, we will start with the first lecture. It is the cervical cancer screening and diagnosis by Dr. Shraddha Ramchandani, who is the consultant gynecologist at AIG Hospitals. Over to you, ma'am.
Hello, everyone. Today I am going to talk about the cervical screening and the diagnosis. So, as all of us know that cervical cancer is one of the most dangerous disease we face, and it is a leading cause of death in women in India. It is the second commonest cancer in India and worldwide. And as you can see that the India and the African countries and the Asian countries, they contribute to most of the part, and 25% of the burden or worldwide burden is from India only. So as far as the natural history of the infection is concerned, in cervical cancer, we know the causative agent that it is mainly in 99% of the cases it is HPV, and there is a very long history about 10 to 15 years from the infection to the full-blown invasive cancer. So lot of time is available from the infection till the development of the cancer, and it goes through the stages of CIN 1, 2 and 3 mostly, and sometimes directly in the high grade lesions can also develop. So regarding the grave nature of the disease, the WHO has an accelerated plan towards elimination of the CS cervix, because we can act in this disease at all the levels for the primary prevention, secondary prevention and tertiary prevention as well. Primary prevention in the form of the vaccines available, and secondary prevention for the detection of all the precancerous lesions and their treatment, and tertiary prevention is the reduction in the mortality in the invasive cancers. So the target by 2030 for WHO is to give 90% coverage for the girls for the vaccination, and then 70% of the women should be screened, at least 70% should be screened for the pre-invasive lesions, and 30% treatment. So what are the strategies available? What are the screening modalities are available with us? So partly we can divide into the high means low resource settings and the good resource settings. In good resource settings, we have the cytological screening and the HPV testing, and we can mostly go with the co-testing, that is both cytology and HPV we combine together, and also VIA, that is visual inspection under acetic acid. And in low resource, limited resource settings, VIA is showing very good results. And the triage tools, once we have screened and we find the screen positive patients, then for the triage, we can always follow them up with the cytology, HPV and colposcopy. So first of all, we will see what we find with the acetic acid. Acetic acid application, in this we expose the cervix properly and we apply the 3 to 5% dilute acetic acid to the area, and then wait for some time, that is about 1 minute, to see the suspicious lesions. The suspicious lesions are seen in the form of the acetovite areas and the different patterns of the blood vessels and the punctate lesions. We have to read the findings immediately after application of the acetic acid, because this is reversible and within 1 or 2 minutes it may reverse. So just to see the suspicious areas and to diagnose the acetovite areas, we have to use this. There are a lot of advantages of VIA, that is it is inexpensive, can be used at the low resource settings, and the people can be trained easily, and it can be used for see and treat policy. And the second is the cervical cytology. We can use the conventional pap smear, as all of us have been doing since ages, and the LBC also, liquid based cytology. Various tools are available for the sample collection, like cytobrush and the IR spatula and the broom. If we are taking sample for the conventional pap smear, we generally take with the cytobrush, which is kept in the endocervical canal, and then it is rotated through the 180 degrees, and we take one sample on the slide, and the second we take with the wooden IR spatula, and from both the sides we take the samples, and we have to make the preparation on the slide as thin as possible and fix it immediately. And for the liquid based cytology also, we collect the sample which can be used for the HPV testing as well. So there it is, the Bethesda system of reporting cytology. This will be covered in detail by the subsequent speaker. I'll just give you a small idea that it can be broadly divided into epithelial cell abnormalities and glandular cell abnormalities. And in epithelial, we see the normal findings: ASCUS, ASCH, LCIL, HCIL. Then next testing is HPV testing. As we know that 99.7% of the disease is attributed to the HPV, and out of this 16 and 18 types, they are most dangerous, which are responsible for the 70 to 80% of the lesions. So these HPV, we do the quantitative as well as qualitative testing can be done. This again will be covered in detail by the subsequent speaker. Then the next is colposcopy. In colposcopy, we see the cervix under magnification and powerful light. We see it with different filters. Then we see it with application of the acetic acid or Lugol's iodine, and we can identify the normal and abnormal cells in the abnormal areas in that. Colposcopy we mainly used for the as a triage tool to take the biopsy from the suspicious area, and when the pap smear, when the cytology is showing any abnormal results. Now, then what is the exact screening protocol in cases of this? So the modalities we have already discussed. The target age is 25 to 65 in good resource and 30 years onwards in limited resource settings. And age to start, we start at 25 years, and we continue it till the age of 65 years. And in low resource, we start with VIA at the age of 30 years. So how frequently we should go for it? When we are using cytology alone as a screening tool, then every 3 years we screen the person in case the result is normal. And if we are using both HPV and cytology together, that is called co-testing, then we go every 5 years. When to stop testing? At 65 years, when the previous reports for at least 2 previous reports are normal, then the woman can exit screening. But if there is any previous report of CIN2 lesion, then at least for 20 years onwards, we have to continue the screening. And one more common question asked is, if the patient has undergone hysterectomy, whether we should continue with the pap smear screening or not. So actually it is not needed if the cervix has been removed in the hysterectomy, and the hysterectomy was done for some benign lesion. But if it was for any CIN, then we have to continue the screening. And in immunocompromised, obviously we have to start the screening at a little early age, and the frequency is also every 2 years. Now, in short, we will see how this flow chart will show us how we are actually going with the screening. When we are using HPV alone as the screening modality, then HPV negative screening, just we will continue as the normal screening every 5 years. But if it is HPV positive, then we have to go with the further triage with the VIS, cytology or HPV. And when the VIA is positive, we go for colposcopy. Cytology positive, we go for colposcopy. And if HPV is positive, we have to just check for the dangerous 16 and 18 serotypes. And if that is there, then we go for colposcopy. All the other findings are there, then we just rescreen them after 1 year, and if it is persistently abnormal results, then only we go for colposcopy and the directed biopsy. And when we are going with the co-testing, how we go about it? Co-testing means we are testing both with HPV and cytology. If HPV cytology both are negative, obviously every 5 years. If both are positive, we will go for colposcopy and directed biopsy. Now the question arises when the one is positive and the other is negative. When HPV only is positive and cytology we see negative, then we just look for the dangerous serotypes. If 16 and 18 are there, then only we go for colposcopy and directed biopsy. And if HPV is negative with the positive cytology results, then the high grade lesions like HSIL and ASCH, we go for colposcopy, and the low grade lesions like ASCUS and LSIL, we just go for the retesting after 1 year, and depending on the results, we proceed further. Now, how to manage ASCUS? If we find the ASCUS, how to go about it? ASCUS we have to combine with the HPV testing if it is available with us, and HPV positive only we go for the colposcopy and biopsy, and HPV negative just continue with the normal screening. And if there is no facility for the HPV, then we repeat the cytology after 1 year, and depending on the further finding, we go ahead with the things. In case of HSIL, again we combine with the HPV test, and HPV positive we go for the colposcopy, and negative again repeat the co-testing after 1 year, and depending on the persistent finding of the HPV positive and abnormal cytology, only colposcopy is needed. If we are doubtful that the patient may not be that much compliant, then directly we can go for colposcopy and biopsy in case of LSIL. Then what about the high grade lesions? If there are high grade lesions like HSIL and ASCH, then definitely we have to go for colposcopy and the cervical biopsy. The difference here is HPV testing is not needed. Even if the finding of HSIL is sufficient to go for the colposcopy and biopsy, and then depending on the finding on the biopsy, we treat it further. What to do if we find the abnormal glandular cells? We may find the atypical endometrial or endocervical cells. In this case, we have to go ahead with the endometrial curettage, and if the endometrial curettage is showing any pathology, we treat it accordingly, and if the endometrial curettage is normal, then we just go with the colposcopy biopsy and further treatments. Same with the endocervical cells, in that we take the colposcopy biopsy and both endometrial and endocervical curettings. What to do if we get the unsatisfactory smear? Sometimes we get the finding of unsatisfactory smear. What to do next? If we have done HPV test already, then just look for it. If that is negative, no need to repeat the smear. But if we have not done the HPV testing, then we have to repeat the cytology after 2 to 4 months. Or we can do VIA also, and VIA positive, then we have to treat accordingly. And how to screen with VIA? VIA screening, as we do in the low resource settings, VIA negative women will undergo the screening as usual at 5 years interval, and VIA positive can directly go ahead with the colposcopy and biopsy, or screen and treat on the same time. So in summary, now we know that cervical cancer is a major cause of cancer mortality in women. And this most of the global burden comes from the developing world, particularly India contributes about 25% of the cases. And if meticulously well organized cervical screening programs are conducted and good cytology services are available, then we can definitely reduce the incidence of cervical cancer and mortality.
Thank you, ma'am. I think that was a very, very exhaustive and very nicely presented lecture. You have highlighted all the different screenings that can be done and the role of HPV. So just a couple of questions from my side. Firstly, in India, in AIG, if a patient just walks in, for example, into your OPD here, wants to do a screening, what would be the method that you would prefer for that patient? Do you go by a risk stratification, or would you do a pap smear for everybody? What's your normal practice?
See, we offer them, we tell them the available things, like normally we would prefer to go for the co-testing, that is both HPV and cytology. But some of the people, they want to opt just for cytology. So it's their choice. If they are willing, we offer co-testing or cytology at least.
Perfect. And I think there's been a very good made in India component, the visual acetic acid inspection method, which has really gone and won many awards internationally as well. It's recognized as one of the best screening methods in India. So I think that's something which we should be proud of, that using a low cost solution for detecting cervical cancer. So that's something interesting. Finally, other thing which you have not really covered, but I'm curious to ask you about, it isn't in the scope of your talk, but I just want to ask you, what's your opinion on the cervical vaccines? Both are good because there's a pentavalent, there's a quadrivalent and a bivalent. So what's your opinion on how effective they are and whether we should encourage patients to take it?
Yeah, we should definitely encourage the patient, but only thing is, when we get the patients, usually the most of the benefit we can get if we vaccinate the girl before she is sexually active. The ideal period is between 9 to 15 years of the age. That is the ideal period, but we hardly get any girl or any parents coming with the girls for the vaccination. We get only in 30s or 40s, we get the women who are willing for the HPV vaccination. Yeah, according to the guidelines, we can definitely offer them the vaccination, but the maximum benefit we can get when the girl is not exposed to HPV and just before the sexual activity.
I think that's a fantastic point, because those people assume that you can take vaccine anytime. It's actually the maximum efficacy is in the early places. And again, we know a lot more about vaccines than we ever wanted to. I think vaccine is the one thing which everybody in the world is talking about now, not necessarily the cervical, but the principle remains the same. We are looking for herd immunity. We are looking to decrease the incidence of cancer. For those who doubt it, there is data from Sweden where they showed that by routine vaccination, the incidence of cervical cancer actually has dropped down. And this is after a period of 15 to 20 years. So vaccines definitely do help, but like ma'am says, we need to know when to vaccinate the patients. That is the most important fact we should look at. So thank you ma'am for that lecture. Next we would be having a session on the pathology. We would be this would be taken by Dr. Swapna, who would be talking to us on the pap smear examination and HPV testing. Dr. Swapna is a consultant pathologist at AIG Hospitals. Over to you, doctor.
Good evening, everyone. Today I am going to discuss about the role of pathology in the pap smear examination and HPV testing. Cytopathology and histopathology form the scientific and the clinical basis for current prevention and treatment of cervical cancer. Cervical cytopathology studies exfoliated cells taken from the surface of the skin, and it is a main method of cervical screening in successful cervical cancer prevention program. Histopathology determines treatment of cancer and pre-cancer through classifying into a diagnosis from biopsy or surgical specimens. Coming to the pap smear, we see in the pap smear superficial intermediate cells, parabasal cells and basal cells, and endocervical cells. We follow the Bethesda system terminology, which provide uniform guidelines for reviewing and reporting gynecological pap test. In the Bethesda following reporting, we see the specimen type, specimen adequacy, and general categorization, which includes the negative for intraepithelial lesion malignancy, epithelial cell abnormalities, and other malignant lesions. Coming to the specimen type, there are two types, which includes conventional and liquid-based cytology. Liquid-based cytology has advantages over the conventional pap smear, in which the cells better preserved and not obscured by blood, mucus, or inflammatory cells. Infectious organisms retained and better preserved. And it is quicker to screen in the report, and in residual material in the vial can be available for further testing, like HPV testing. Coming to the pap smear adequacy criteria. So the minimum number of visualized squamous cells for adequacy are, in the liquid-based preparation, minimum of 5,000 cells should be seen, and whereas coming to the conventional preparation, 8,000 to 12,000 cells should be seen. If the obscuring elements cover more than 75% of the epithelial cells, it is unsatisfactory for evaluation. If we are seeing few abnormal cells also, it should be considered as adequate and it should be reported. Coming to the non-neoplastic findings, the various findings which include are reactive cellular changes, squamous metaplasia, atrophy, and few organisms and others. Coming to the squamous metaplasia, in this the cells will have sharply defined cell borders with round central nuclei and usually the normal nuclear size, and the main thing is dense thick cytoplasm will be seen, which is prominent for the squamous metaplasia. Reactive cellular changes which can be associated with inflammation, post radiation as well as IUDs. Coming to the changes associated with inflammation are, here the cells are usually slightly increased in size with normal NC ratio, and the nuclei will be normal in size with 1 to 2 times increased in the size with the binucleation and multinucleation, and the nuclei will be smooth, round and uniform with vesicular hypochromatic nuclei. Usually single or multiple nuclei will be seen with the polychromasia. We have to differentiate between the reactive cells with inflammation versus neoplasia. The main things which we are seeing in the neoplasia are the cellular arrangement will be in sheets and the nuclear polarity will be lost, and the mitotic figures will be atypical and prominent. Coming to the reactive cellular changes associated with radiation are, the cells are markedly increased in size in case of associated with radiation, and there will be variable binucleation or multinucleation. Normal NC ratio will be seen, and the nuclear membrane will be wrinkling, smudging, and show nuclear vacuolations. The nucleoli can be multiple or single. The reactive cellular changes associated with intrauterine contraceptive devices are, here we see the changes mostly in the glandular cells which are in 5 to 10 clusters and mimic like a signet ring cell carcinoma. In this case, we have to take proper history from the patient. Next is atrophy with, it can be associated with or without inflammation. It is most commonly seen in low estrogen states like premenarche, postmenopausal and postpartum. In this we see predominantly of parabasal and basal cells. So these cells will mimic HCl, but they will be having finely granular chromatin with smooth nuclear contours. The nucleus will be enlarged. Background will be showing inflammation, debris, naked nuclei, but there won't be any karyorectic nuclear debris where we can differentiate from the tumors. The organisms found in the pap smear are Trichomonas vaginalis, which are pear-shaped, pale, eccentric, elongated nucleus with red cytoplasmic granules. Candida, these are eosinophilic yeast forms with pseudohyphae and spores with tangled skewering squamous cells, appears like a spaghetti and meatball appearance in the pap smear. Cellular changes associated with herpes simplex virus. These cells will be having molding of the nuclei, multinucleation, margination of the chromatin, and the cells appear with the glass ground chromatin and eosinophilic nuclear inclusions. Coming to the actinomyces, these are gram-positive anaerobic bacteria, and they look like long filamentous organisms tangled with clumps of bacteria that look like cotton balls or dust bunny appearance. Bacterial vaginosis. Clue cells are the characteristic feature for the bacterial vaginosis. In this, the squamous cells are covered with the shaggy bacilli rather than normal lactobacilli. Coming to the epithelial cell abnormalities, which include squamous as well as glandular. Coming to the squamous cells. Atypical squamous cells of undetermined significance. In this, the nuclear size will be 2.5 to 3 times of the normal nuclei with slightly increased NC ratio with minimal hyperchromasia. And when the atypical squamous cells cannot exclude HCl, these are the cells with small cells with high NC ratio and crowded sheet pattern with loss of polarity with dense cytoplasm. Low-grade squamous intraepithelial lesion. These look like mature keratinocytes arranged in sheets with increased in size. The nucleus is 3 to 5 times of the normal nuclei with variable binucleation and multiple nucleation. The NC ratio is slightly high when compared with the HCl. The chromatin is coarsely granular and evenly distributed. The nuclei may be absent or inconspicuous. The nuclear membrane is slightly irregular. The cytoplasm will be having distinct borders. Perinuclear feature is a feature for the L cell. HCl. Here the cells are arranged in less mature single sheets and syncytial aggregates. When compared with the L cell, the chromatin will be evenly distributed and nucleoli are absent, and nuclear membrane will be quite irregular with prominent indentation. And the cytoplasm will be immature, dense metaplastic and with keratinizing cytoplasm. Coming to the squamous cell carcinoma, the mainly pattern will be in isolated cells or less commonly in aggregates with marked variation in the cellular shape, and there is marked variation in the nucleus. with coarsely granular irregular distribution. Nucleoli are usually less common but seen in the large cell type. Background showing the tumor diathesis, which is the main feature for squamous cell carcinoma. Coming to the variants of squamous cell carcinoma, here we can see the squamous cell carcinoma keratinizing type, and next is the squamous cell carcinoma non-keratinizing type, and the last is the non-keratinizing large cell variant, which has a prominent eosinophilic nucleoli. These are the various points which differentiate from the reactive changes with L-cell, H-cell, and the squamous cell carcinoma. Coming to the next, epithelial cell abnormalities, glandular type. In this, there is epithelial cell, endocervical cells atypia, NOS, and endocervical cells atypia favors neoplastic, endocervical adenocarcinoma in situ, and adenocarcinoma. Atypical endocervical cells not otherwise specified. In this, the cellular pattern will be like in the single strips or with minimal overlapping and crowding, and the nucleus will be increased in size like 3 to 5 times of the normal nucleus size with little variation with high NC ratio with mild hyperchromasia. The main thing is nucleoli will be prominent here. The cell nuclei will be round in shape with the distinct cell borders. Atypical endocervical cells favor neoplastic. In this, the cellular arrangement will be like rosetting and feathering pattern. Crowding and nuclear overlapping is there with the nucleoli are seen, and the nuclei will be like elongated. In this side, decreased with cytoplasm is showing distinct ill-defined cell borders. Endocervical adenocarcinoma in situ. In this, the cytoplasm tags and feathering will be there. Nucleoli will be inconspicuous, and chromatin will be coarsely granular and even distribution. Background will be clean. Coming to the endocervical adenocarcinoma, mostly they are arranged in single cells with 2D sheets and 3D clusters. The nucleus will be enlarged pleomorphic with coarse irregular clearing, and the prominent macronucleoli will be seen with finely vacuolated cytoplasm. Background will be seen tumor diathesis. Atypical endometrial cells. In this, the cells are arranged in small groups of 5 to 10 cells with a slightly enlarged nucleus with mild hyperchromasia and small nucleoli with ill-defined borders. Endometrial adenocarcinoma, these are arranged in tight clusters with loss of polarity and coarse irregular chromatin and prominent nucleoli with cyanophilic or vacuolated cytoplasm. Background shows watery diathesis. Other malignant neoplasms which can be seen in the PAPs are spindle cell carcinoma, small cell undifferentiated carcinoma, malignant mixed mesodermal tumor, sarcoma not otherwise specified. Coming to the HPV testing, the HPV virus are the double-stranded DNA circular DNA virus which infects the epithelial cells in the cervical mucosa. HPV DNA integrates into the cellular genome when causing cancer. The viral genes responsible for transforming host cells into cancer cells are E6, which inactivates the P53 and blocks the apoptosis, and E7, which inactivates the RB gene, which is responsible for the uncontrolled growth. There are many subtypes of HPV. In that, HPV high risk are 16, 18, 31 and 33, which are associated with cervical cancer and HCL. And type 16 is most commonly detected in cervical cancers. Type 18 is associated with endocervical adenocarcinoma. Low risk subtypes are 6, 11, 42, 43, which are associated with LCL and condylomas. Most HPV infections are subclinical and will cause no physical symptoms. In some cases, the subclinical infections become clinical and may cause benign papillomas, pre-malignant lesions that will drive to cancers of cervix, vulva, vagina, and anus. HPV testing. The detection of HPV infection in genital samples may increase the sensitivity of primary and secondary screening of cervical cancer. This testing may also improve the specificity of screening programs, resulting in avoidance of overtreatment and cost saving for confirmatory procedures. The major determinants of clinical progression of HPV infection include persistence of HPV infection, involvement of high-risk HPV types, high HPV viral load, integration of viral DNA, and presence of several potential cofactors. There are various diagnostic tests for HPV detection: electron microscopy, culture, antigen, in situ hybridization, and several other things. Which we follow common is qualitative PCR HPV DNA, which is based on the amplification of specific regions of the HPV genome. The amplified product is detected via fluorescent dyes. So the lower limit of detection for HPV is 50 copies per reaction. So the introduction of DNA testing for the presence of HPV has increased the effectiveness of screening programs for the detection of cancer. Thank you.
Thank you, Dr. Sapna, for illustrating the various ways of diagnosing HPV, the cervical cancer. Nowadays, we do use only the liquid fixatives, right? That's what initially they used to have only stay slides, but now even the liquid fixative it is done. Yes. So has that really made a difference in terms of your outcomes of detecting, or is it the same?
There is a difference, sir. In the liquid-based cytology, we usually see the low inadequate rate, and the background will be clear. There won't be any blood mucus, and organisms will be well preserved, and inflammatory cells will be little less when compared with the conventional pap smear. And this liquid-based cytology, this liquid can be used later for the HPV testing, which we cannot do
that's
for
an
the
important thing. That is, so do not throw away the liquid. The liquid can still be used for DNA testing.
DNA testing.
Very good. That's something I was not aware of. So thank you so much. Next, we will be going on to the role of the surgeon, and the speaker would be Dr. Sridhar, who is a consultant surgical oncologist. He will be talking about how to do the surgeries for the CA endometrium, and would also cover a couple of slides probably about the CA cervix surgery as well. So over to you, Dr. Sridhar.
So thank you, Dr. Vamshi, for inviting me on this for this webinar on management of surgical management of endometrial cancer. I will also be talking about surgical management, a few brief slides on the management for cervical cancer also, but mainly my topic will be covering endometrial cancer. So, among the gynecological malignancies, endometrial cancer is the fourth most common worldwide, and in the United States of America, it is actually the most commonest malignancy among women. That is the most common gynecological malignancy among women, and fourth most common malignancy overall among the United States, and worldwide it is the sixth most common gynecological cancer. So in India, there is an increasing incidence year on year because of the change in the lifestyle patterns as well as the dietary patterns. So per annum, we have about 13,328 cases, and especially in urban areas such as in Bombay, Hyderabad, and Bangalore, there is a definite increase in the incidence. So even then, the most common age group where it is seen is in the postmenopausal age group, that is constituting almost 80%. But there is a significant number, almost about 1/5, that is about 20% who come in the premenopausal age group. And below the age of 40 years, about 5% of endometrial cancers constitute that part. So in this age group, we have to always look for hereditary causes for endometrial cancer, like the Lynch syndrome, as well as the HBOC, or the hereditary breast and the ovarian cancer, which is the BRCA mutation. So all the data is from the Globocan 2018 on the WHO website. The risk factors. So the risk factors for endometrial cancer are essentially unopposed estrogen action, similar to that which is seen in breast cancer. So more number of menstrual cycles, that is early menarche, late menopause, nulliparity, because nulliparous women do not have the progesterone surge which is seen during a pregnancy. And as I said, genetic factors, the two common syndromes are the HBOC and the Lynch syndrome, especially Lynch 1 and 2. Endometrial cancer is almost one of the pathognomonic cancers which define Lynch syndrome. And the treatment history of sequential oral contraceptive pills. In postmenopausal women, the use of tamoxifen has been associated with an increased incidence of endometrial cancer, and especially in stromal sarcomas. So generally endometrial cancers are present early, unlike cervical cancers, which generally present especially in countries such as India. They are very neglected and they present late. So that's why they are picked up early, because the common symptom is postmenopausal bleeding. Because once the woman has attained menopause, any bleeding she automatically ascribes it as a pathological bleeding. But in cervical cancer, because the age group is somewhere between the 40 to 60 age group, and most of the time it presents as a postcoital bleeding, because the cervix, the ectocervix is the one which is involved, and that is why during the coitus there is some amount of a disruption of the tumor cells and there is bleeding. But this is always ascribed to the act of sexual intercourse, and therefore it is neglected by the patients. In the perimenopausal age group, sometimes the women are present with menorrhagia, which again is generally ascribed to dysfunctional uterine bleeding and not ascribed to endometrial cancer per se. In late cases, endometrial cancer behaves like advanced ovarian cancer with peritoneal disease and therefore attendant weight loss, back pain, and with local regional organ involvement, it may present with hematuria as well as sometimes even hematochezia or lower back pain and even bilateral pedal edema. So generally, endometrial cancer for the large duration of time, it was classified into two clinical, pathological and morphological forms. That is the type 1 and the type 2 cancer. Where type 1 cancer is due to the estrogen excess, it is commonly seen among perimenopausal women. The women have something like the metabolic syndrome where they're obese, they're hypertensive, they're diabetic, and most of the tumors are early stage, early grade, well differentiated, and the endometrioid subtype. Whereas the type 2 tumors are commonly seen in asthenic women, postmenopausal, estrogen independent, very thin people, very thin patients, and they have a non-endometrioid histology, poorly differentiated, and because of these reasons, they generally present at a later stage. But with the recent advances in the genetic mutation analysis, we now have 4 different types based upon the molecular typing, where it is called as the pole hypermutated and the MSI hypermutated, the copy number low and the copy number high. But as of now, from the surgical point of view, in general, the type 1 and the type 2 endometrial cancers still hold good. So the differential diagnosis, again, it could be cervical cancer, especially in a perimenopausal age group. Cervical cancer is actually more common than endometrial cancer. Atrophic vaginitis in the postmenopausal age group, the most common cause of postmenopausal bleeding actually is not endometrial CA, it is atrophic vaginitis. And sometimes you might have the benign variants of endometrial cancer, that is endometrial hyperplasia, submucosal endometrial polyps. So the bottom line is that any postmenopausal bleeding has to be considered as abnormal until proven otherwise. Especially, and this is the take-home message for all women, that you should not neglect any cause of postmenopausal bleeding. So the history and the physical examination are extremely important for any gynecological cancer, whether it be cervix or the endometrium. So the physical examination, one should always look for the vulva, the vagina, the cervix. So we have to see if there are any lesions in the cervix, either by the clinical examination by a Cuscos or a sim speculum, or sometimes even go for a pap smear testing, colposcopic examinations. And pervaginal and rectovaginal examination may reveal whether there is any parametrial involvement, either due to a cervical growth or due to an advanced endometrial growth. Adnexal masses can be palpable. And per abdomen is important because, especially from the surgical point of view, the previous scars, like for any hernia surgeries or previous LSCS, may impact the intraoperative decision making, whether you could go for a minimally invasive approach, or sometimes you may have to go for an upfront open operative surgery approach. And of course, advanced cancers may present with ascites, peritoneal nodules, omental caking, hepatomegaly. And one should always look for other signs, especially endometrial cancer of estrogen excess, especially breast cancer, because breast cancer and endometrial cancer are both diseases of estrogen excess. So there might be a concomitant even breast lump which might not have been brought to the attention of the patient. Groin examination, because advanced cancers may present with groin lymph nodes, lower limbs, back for back pain and metastasis. So the investigations. So the investigations for endometrial CA is the first and the foremost investigation for any postmenopausal bleeding is to check the status of the endometrium. And the most sensitive investigative modality is a transvaginal ultrasound. Now the cutoff for the endometrial thickness has become progressively smaller. It used to be 6 mm. Then because of the high sensitivity and the poor specificity, it was then cut down to 5 mm. Now it is now about 4 mm or greater is deemed to be abnormal, because you don't want to miss more number of endometrial cancers. The MRI pelvis. So the MRI pelvis with the abdominal screening is the investigation of choice for cervical stromal involvement. But nowadays MRI is also used for checking for any endometrial myometrial involvement. So there are a large number of studies and data which is coming up, which are looking for the correlation between the frozen section intraoperatively and the MRI myometrial involvement, and whether there is any correlation. Most of the time, most of the studies are showing that an MRI which shows more than 50% myometal involvement is correlating with the final histopathology of more than 50% myometal involvement, because this upstages the patient preoperatively, and we can also go for some form of sentinel lymph node mapping for the nodal evaluation in these kind of patients. So CT abdomen with IV contrast for distant metastasis. Most clinicians or surgical oncologists will use a CA-125 just to look for occult peritoneal disease, especially when the lesion is more than 50% myometal involvement. Mammogram just to rule out any incidental breast masses which are not made out by the patient. The tissue diagnosis, we have various tissue diagnostic modalities. In the olden days, any patient who was presenting with a perimenopausal or a postmenopausal bleeding underwent a DNC, most commonly under sedation or an examination under anesthesia. But nowadays we have very simple procedures. We can use a pipple or a Jabra needle, which has got which are office based. It is done under no anesthesia at all, and the patient is very less inconvenienced by these procedures, and they've got extremely high sensitivity, close to 90 to 95% as compared to DNC. And with the advent of minimally invasive techniques and endoscopic visualizations, so histoscopic guided biopsies are also being pushed forward, and they also have an extremely high sensitivity and specificity for endometrial lesions. For cervical cancer, most of the time the growth is visible. You can just go for a punch biopsy, and as madam has already told beautifully, that for lesions where the pap smear is finding is not correlating with the clinical examination, one can go for a visual inspection with acetic acid, leukocytine, that is called VIA or VILI, and also for any colposcopy, especially the pap findings and the clinical examinations are not correlating. So the surgical staging, the staging of endometrial cancer to this day is still a surgical staging, and generally a lesion which is confined to the uterus is considered stage 1. Anything which is more than 50%, in anything which extends beyond the uterus, that is to the vagina or the parametrium, is called stage 2. Node positive involvement is stage 3, and distant metastasis is stage 4, or locoregional organ involvement also makes it stage 4. So there are certain surgical options which is generally the diagnostic and the curative treatment of choice, but there are also certain non-surgical options, especially for women who are young and they have a desire for fertility preservation. There are very few indications, however. First of all, there should be no myometrial involvement. That is, in the old staging, it is 1A, that is purely endometrial confined growth. That is, there is no myometrial involvement at all. There should be no contraindication to progesterone use. That is, the patient should not have uncontrolled hypertension, obesity, and then it should be a well-differentiated tumor. Then what the patient has got an option is to go for a therapeutic DNC. That is, you have to completely scrape out all of the diseased endometrial tissue, and then you have to give progesterones. So the commonly used ones are medroxyprogesterone acetate and megestrol acetate, and you can use an oral route or a IUCD with a combination with an oral route. Ideally, we should give the lowest effective dose because the higher the dose, the higher will be the side effect profile, and even the compliance will be poorer. Once you do a therapeutic DNC and you start off this progesterone treatment, then the subsequent evaluations do not require another DNC. You can just go for an office-based endometrial sampling. So in cervical cancer, also there is a role for non-surgical options. So for microscopic cervical disease, then we have options like cold knife conization or LEAP. Whereas for macroscopic disease, in a fertility, if a patient desiring fertility, it is confined only to lesions which are between less than 1B2, that is less than 4 centimeters, which is visible, or a 2A2, that is whether vaginal involvement is only confined to the upper third. So anything beyond that, you cannot go for a fertility preservation. And in these patients, the option is what is known as radical trachelectomy, where the entire cervix from the external os to the internal os is completely excised along with a cup of the parametrial tissue, and a nodal staging is done in the form of either a sentinel lymph node biopsy if the imaging does not show any involved lymph nodes, or one can go for a therapeutic lymph node dissection through a minimally invasive approach, that is a laparoscopic or endoscopic approach. So this is the treatment algorithm for fertility preservation in cervical cancer. So as I said, in endometrial cancer, once we go for a therapeutic DNC and we go for progesterone use, then we have to evaluate. So the first evaluation occurs at 3 months, that is 12 weeks. If there is most of the time there is a complete response in almost 70%, and the pregnancy rates are close to 30%. So 1 in 3 women who opt for this, who pick the strict diagnostic criteria, will land up with a good pregnancy, and the live birth rate of about 30 to 50%. So the second evaluation should be at 24 weeks. That is at least at 6 months. And if the complete response persists, only then they should go for conceiving. So that's the first evaluation should be at 12 weeks, next at 24, and then finally conceive after that. So this is a simple video which I am going to show you regarding the general treatment which is nowadays done for most gynecological cancers, that is be it cervix or endometrium. So the general staging procedure is a staging laparoscopy. That is, we go for a diagnostic laparoscopy and check whether there is any peritoneal disease. Then there is no role routinely for going for any peritoneal wash cytology, because unless there is any significant visualized peritoneal disease. So once we use a standard 5-port approach and we start our dissection by cutting the round ligament. The difference between an endometrial CA and a cervical cancer is you will go for a cervical cancer radical hysterectomy only if there is a viable growth which is more than about 4 centimeters in size. And second thing is every part of the surgery is more radical. So we have now incised the round ligament somewhere in the midline between the exit into the deep ring and its entry into the uterine cornu. Whereas in a cervical cancer, we will go much more laterally. So once we do that, then we open the anti-relief of the broad ligament, and with the help of either a harmonic shears or sometimes even with a monopolar cautery, we are now creating the bladder plane. So the bladder plane is important because in endometrial CA we go, as we know, the treatment is an extrafacial hysterectomy. So the term extrafacial hysterectomy means basically we preserve the facial layers of the uterus on the uterus itself. We just go just outside the facial envelope. Whereas in cervical cancer, we go extremely radical. So we cut the round ligament as lateral as possible, and we dissect the bladder also almost up to the bladder pillar area. So the role of doing a good physical examination is, especially if the patient has got a previous LSCS, which is nowadays very common. So most obstetricians will try to reperitonealize this UV fold, and therefore this bladder plane may be obliterated by dense adhesions. So in this case there was no LSCS, so we are just going through the anterior approach. Otherwise, sometimes what we do is we go very laterally. We approach the bladder laterally by creating a plane, and then we dissect the bladder down. So now we can see that the ureter is there, and there is a ribbon-like structure going over the ureter. This is the so-called ureteric tunnel, where the uterine artery, which is a branch of the internal iliac artery, anterior division of the internal iliac artery, is crossing over the ureter. So this much amount of dissection is not required for doing a simple extrafacial hysterectomy, but it is generally good to see the ureter, because inadvertently sometimes the ureter may make its way, especially as we go low down, because it also enters the bladder anteriorly. So once we see the ureter under vision, we can lateralize the ureter and give a posterior peritoneal cut and make our way to the uterine artery area as it enters into the uterus. So we can see that the uterine artery, the coiled structure, is well made out here. So the uterine artery gives an ascending branch and a descending branch. So the ascending branch goes to the uterus, and the descending branch goes to the cervix and the vagina. The difference between radical hysterectomy is in this area, because this constitutes the so-called parametrium, and the region lateral to the vagina is called the paracolpos. So this is where microscopic spread of tumor may occur in cervical cancer, but unlike in endometrial cancer, and we go very laterally there. So once this is done on the right side and we have ligated the uterine artery, the same steps are repeated. We see the ureter on the left side, and we lateralize the ureter, and we go extremely close to the uterus for ligating the uterine artery. So how do we manage uterine artery? There are various methods. One is you can go for, and this is a ligosure device, which is a vessel sealant and can be used for ligating vessels up to 5 millimeter very, very safely. Some people also use clips. So once we do, and once we have taken the uterine artery, then this is the area of the bladder, that is the bladder pillar. So the bladder pillar, there are only 4 or 5 steps in extrafacial hysterectomy. First is to go for a cut the round ligament. Second is to go for an anti-peritoneal cut. Third is to go for a posterior peritoneal cut, and the fourth is to drop the bladder. So once we drop the bladder and we palpate the vagina, and we actually put a vaginal pack from below. So once we know that the cervix is completely made its way out of the operative field, then we can go for a colpotomy. So we don't normally use a uterine manipulator because there have been some studies, especially in cervical cancer, which have shown some amount of local recurrence. In fact, there is a LAC trial which showed that there is a detrimental survival with minimally invasive radical hysterectomy. And one of the reasons which they mentioned was that they commonly used a uterine manipulator and they did not give a good uterine or a vaginal wash. So for any form of hysterectomy, we try to avoid any manipulation either of the uterus or the cervix. So once we have given an anterior colpotomy, we have to create the plane that is posterior to the uterus. So here we can see the rectum, and the fat belongs always to the rectum, and the fat always belongs to the bladder anteriorly. So any fatty tissue which is there should be completely swept down and ensure that it is away from the posterior vaginal wall. So once this is done, then we can go for a colpotomy. So the colpotomy can be done either by, as I said, by the harmonic scalpel or by using a monopolar surgical device. And ideally, it is good not to completely devascularize the vagina because it might result in wart recurrence. So in endometrial CA also there is a role for ovarian preservation. In general, the menopausal age in Indian women is about median age is about 52 years of age. So if the clinically, if any woman is less than say about 40 to 45 years, we have to preserve the ovaries, even though endometrial CA being a estrogen dependent tumor, the psychological impact on the patient as well as on the bone and the cardiovascular system is too great, and therefore we have to preserve the ovaries. If we think that the stage on table is going to become slightly higher and the patient may receive postoperative radiation, then these same ovaries have to be mobilized and they have to be tacked in the paracolic gutter. That is, they have to be transpositioned. The same thing also in cervical cancer, because cervical cancer there is not an estrogen dependent tumor either ways. So ovarian preservation is the rule. So once we take the specimen out, from the majority of the specimens will be possible to be retrieved through the vagina. So once we take the specimen, it's not, our job is not done. We should check for any tears in the vagina, because this might cause some bleeding in the postoperative period. We have to go for a good wash, and then we have to suture. This can be done intracorporally or extracorporally. Most of the time people are doing an intracorporeal suture. So we do a continuous running suture with the Vicryl, and especially women who are in the who are quite young, and there is a you have to always suture, if possible, the uterosacral ligament. So this is the uterosacral ligament, and one stitch is taken to the uterosacral ligament to prevent postoperative vault prolapse, especially in the elderly age group patients who have got a poor pelvic floor musculature. And then we close the ports using a port closure device. So node dissection. When do we go for node dissection? Essentially, we stratify patients into 3 types, that is low risk, intermediate risk, and high risk. So this is based upon a GOG study which showed that as the depth of myometal invasion keeps on increasing, there is a higher chance of nodal involvement. So endometrioid histology grade 1 to 2 is low risk. A simple hysterectomy is adequate. Intermediate risk patients, that is 1A grade 3 or 1B. So this, how do we know about it? So until we reach the final histopathology. So the original GOG guidelines stated that you have to go for a complete pelvic and a para-aortic lymph node dissection for all patients. But nowadays we have facilities like on-table frozen section, where in which you have we can just remove the specimen, send for frozen, and if it is showing 1B or 1A grade 3, then we can go for a SLNB or a pelvic lymph node dissection. So any patient who's got a stage 2, that is on clinical examination or MRI examination, if there is a parametal involvement or a non-endometrioid histology like a clear cell or a carcinosarcoma or a serous carcinoma, we have to go for a formal lymph node dissection. So this is surgical video showing the sentinel lymph node biopsy. So we inject ICG. We can use a gamma probe. We can use even isosulfan blue also. So this is a SPICE system, Karl Storz, whereby which we inject ICG. ICG is actually a dye which has got almost no renal excretion. Majority of it goes to the liver, and it is extremely safe even in patients who have got elevated creatinine levels. So we injected at a 3 o'clock and 6 o'clock position just before pneumoperitoneum, after putting all the ports, and over a period of about 5 to 6 minutes, it makes its way to the first echelon group of lymph nodes. So this first echelon can be anywhere. So for endometrial cancer, it need not be the pelvic nodes or the obturator nodes. It can sometimes even go directly up to the para-aortic nodal area. So we are dissecting the node, and then we are again checking it by spacing the SPICE system, and by completely ensuring that we can see that the lymphatic channel is draining to the lobe. So this most likely is the sentinel lymph node, and by taking care of the there you can see that there is the obturator nerve. So this is actually an ilio-obturator group of lymph nodes, which is the sentinel lymph node, and again we just confirm it that this is the involved node, and we send it for frozen section. So once this is done, just before removing the node, we are just checking it ex vivo. Yeah, we can see that there is a good amount of fluorescein uptake, and we send it for frozen section, and if it comes positive, then we go for a complete pelvic lymph node dissection. So the complete pelvic lymph node dissection, the classical lymph node dissection starts laterally from the genital branch of the genitofemoral nerve, and medially we go almost up to the ureter, and posterior up to the obturator, and proximally up to the common iliac vessels. So we can see now this is we are completely bearing the fascia of the common external iliac and as well as the common iliac artery. This is the external iliac vein, and most of the centers they do go lateral to the common iliac vessels, but we generally don't go there because that is the lymphatic drainage of the lower limb, and it is extremely rare for an endometrial CA or even for a cervical CA to make its way to lymph nodes lateral to the iliac group of vessels. So we confine our lymph node dissection to the ventral as well as the medial surfaces of the external iliac artery as well as the vein. So once we go and we finish this is the iliac group of lymph nodes, we make our way to the obturator fossa. So we can see this is the obturator internus muscle, and the that is the fascia. We can see that the obturator nerve along with its obturator group of vessels, and we go proximally, and we divide the lymph nodal packet. So medially there is the obliterated hypogastric group of obliterated hypogastric artery, which forms the medial border of dissection. So this is the obliterated hypogastric, and here we have the ureter. So once we are dividing the last packet, it's extremely important to see where the ureter is, because sometimes we can inadvertently damage the ureter. So this is the ureter. We check for the peristalsis, and we cut the peritoneum just lateral to the ureter, and do a complete our pelvic lymph node dissection. This is the completed pelvic lymph node dissection. So the same is done on the both sides, and the next is the para-aortic. So para-aortic lymphadenectomy, again, if there is our practice is that if there is any pelvic lymph nodes positive, then we definitely have to go for a para-aortic lymph nodes dissection and not a sampling, because the incidence could be as high as 20%. So this is a picture where in which this is the IVC, this is the aorta, this is the interaorto caval region, which is completely been bared of all the lymphatic tissue, and this is the left renal vein, and this is the duodenum and the pancreas. So this entire from bilateral ureters laterally and proximally we have to go almost up to the renal vein. This is the formal para-aortic lymph node dissection. So the role of para-aortic lymphadenectomy in cervical cancer is not proven, and there is some data to show that in radiation that para-aortic strip radiation may be beneficial in some group of patients in cervical cancer. In endometrial cancer, if we have para-aortic lymph nodes positive, definitely we have to give radiation even to the para-aortic group of lymph nodes. So to summarize, the surgery is the mainstay of treatment for endometrial cancer, with radiation being an extremely good adjuvant treatment option. For cervical cancer in early stages, radiation as well as surgery are equally efficacious, whereas in advanced stages, chemoradiation is the treatment of choice. Sentinel lymph node biopsy is the way forward for evaluation of nodal disease, be it cervical or endometrial cancer. So fertility preservation techniques do have a role to play in very early stages of endometrial CA. And whenever we have a young patient, we should look for a hereditary component like Lynch syndrome, good for a colonoscopic evaluation. Look for any lesions in the breast, go for a mammographic screening. And MRI has a definitely increased role in staging, especially because it helps us in guiding our surgery from the preoperative perspective. Thank you.
Just a quick question. Right now, what is your opinion on the role of MIS in cervical cancer? Should we still go with it, or based on those trials, shall we say that the age of MIS is done?
Yeah, so for cervical cancer, based upon the LAC trial studies, there is almost universal consensus that you shouldn't go for minimally invasive surgery.
Okay.
But there are certain pitfalls. For example, most of the centers were quite low volume centers. And as I said, a large number of patients did use uterine manipulators. So uterine manipulator is an extremely invasive device. You put it into the endometrial lumen, and especially when we use it for cervical growth, then there is a high chance of seeding, especially of the local vaginal area and the vault area. Okay. So centers where single institution centers where they do not use a uterine manipulator, their argument is that this could be one of the reasons for the high chance of local recurrence. But again, I feel that volume makes a big difference, because even open cervical radical hysterectomy is one of the most technically challenging operations. And if you do not do more than, say, about 50 to 50 cases in a year, I would still say that even you should go ahead with a open surgery, because the outcomes are definitely better in open surgery, especially in low volume centers. So it should be confined only to centers which do extremely high volumes of a minimally invasive. But for endometrial cancer, definitely the treatment of choice is minimally invasive, maybe robotic or laparoscopy.
Thank you. I think that was a very nice lecture, sir. Now, next topic would be radiotherapy in carcinoma cervix. Like Dr. Sridhar said, wherever in a slightly higher stage of cervical cancer, their surgery and radiation are pretty much equivocal. In more advanced stages, chemoradiation is the therapy of choice. So, over to Dr. Kaushik Bhattacharya, who is the consultant radiation oncologist and the head of the department at AIG Hospitals, for his talk on radiation in cervical cancer.
Good evening. So, in our session of gynecological malignancies today, cervical cancer is a very special type of cancer, because at one point of time it was the #1 killer of women in India and most of the third world countries. And this is also one of the models where early diagnosis and prevention techniques can bring down the mortality and the morbidity to the point that the disease is expected to be vanishing from most of the world one day in our own lifetime. Now, why it is also important is that the outcome can change so radically depending on what stage we intervene. A very early diagnosed, screening diagnosed cervical cancer can be 100% curable with minimal mortality, minimum morbidity for the treatment. Whereas on the other hand, every radiation oncologist or surgeon who's been of my generation and has seen this disease evolve over the last 20 years or so, or 30 years or so, have seen those days where most of the patients in cervical cancer were in stage 3B, where the long-term survival is only 30%, and they die a very painful death of local recurrence, uremia, and such. Now, surgery is a very, very important part of cervical cancer management. But in India, a significant number of these patients will actually not be able to receive surgery for the reason that they will not be diagnosed in the stage where you can do a good surgery. And they willy-nilly end up in the hands of radiation department. And therefore, before I go into the details of the radiation techniques and occurrence, indications and such, I'll give a brief introduction to what is radiation oncology. Now, radiotherapy, you can have radioactive rays which can be naturally occurring, like alpha, beta, and gamma rays, of which the gamma rays are the ones which are used for gamma rays or photons or X-rays, as we call them, are used for therapeutic application, because they can penetrate deep into the tissues and they cause oxidative damage to the DNA. And the normal tissue has a selective capacity to recover from that. So that leaves the tumor dying off more than the normal tissue, and there you achieve a therapeutic ratio. In clinical practice, the sources of radiation could be from cobalt-60, which is not done anymore because they are poor quality, general, obsolete now. The linear accelerator is the standard of care now, standard device now, which can be high or low energy. These are electronic equipments and very sophisticated, uses computerized dosimetry, huge scope of customization. And the biggest advantage of a linear accelerator is that it leaves no residual radiation. You switch on the system and there is no more radiation. So there is no radiation contamination of the patient who has been treated, unlike what could be due to, say, cobalt, where the department remains radioactive throughout the day, whereas that is not the case here anymore. And in fact, right now all the centers are only having linear accelerators of various sophistication. And in cancer cervix, a very, very important thing is brachytherapy, which is essentially a direct placement of the radioactive source inside the tumor tissue. And why it is so important, I'll come and tell you in the later part of my presentation. As I told you that cobalt-60 treatments were from the olden days. I don't think any centers in the country right now still, I don't know, I'm very honest, I don't know anyone still using them. Moved on to linear accelerators, basic linear accelerators, which have subsequently been upgraded with a technical capacity to shape a beam to the shape of the tumor. Now, tumors are not really square or rectangular, they have odd shapes, and the beam should also be shaped oddly. Extensive use of CT scan and MRI to do the radiation planning so that a three-dimensional reconstruction can be done and those plans, etc., can be decided accordingly. Advanced techniques like IMRT and IGRT, although the role of IMRT or image guidance is a little bit limited in CA cervix, but still they are there. And of course, stereotaxy is the other option, which although in cervix we don't see much of use of that. Now, coming back to what my previous speakers have already told, I just touched upon them very briefly. Worldwide, it's a disease of the developing countries, and we have 500,000 new cases every day with 270,000 deaths, which, if you consider many other cancers, this is a cancer which could be actually each and every patient could be saved. But such a high burden of death points towards only one thing, that our society's apathy to the health of a woman. In India, it's a disease which is primarily concentrated in the rural areas, and there you see approximately 25% of all female cancer patients actually suffer from cervical cancer. A majority of them land with us in an inoperable stage because of the parametrial involvement. The key risk factors are multiparity, early marriage, failure of screening programs. Screening programs in our country exist only in paper. So failure of screening programs are one of the major reasons that we see so many of them. But in my lifetime, I have seen the number of cervical cancers becoming much less in the last 20 years or so. So I can only have a hope that it will be further down and the most vulnerable component of our community will not continue to suffer from this disease. Staging, basically the staging is very simple, whether from the radiation oncologist, the surgeon's perspective is concerned, whether the disease is confined to the cervix or it has gone beyond the cervix, whether it's confined to the cervix or gone into the parametrium and the vaginal thing. So the early stages are amenable to surgery, and the late stages where you do not do surgery, you have to treat with something else. Now, one key thing is that cervix involves the pelvic nodes, and depending on stage, in stage 1 up to 10% of the patients will have pelvic nodal involvement. In stage 2, approximately 23% or so will be having involvement of the pelvic nodes, and in stage 3, up to 30% of the patients will be having pelvic nodal involvement. And therefore, management of the node is a very core part of management of cervical cancers. And therefore, if you see the relative role of brachytherapy and external radiotherapy, it essentially depends on what stage that patient is in. By the time you are in stage 2, you have up to 20% pelvic nodal involvement, so that external radiotherapy becomes a mainstay of treatment, whereas in stage 1, only brachytherapy can be offered as an option. Now, I will just go by site-wise indications very briefly. In all stages, be it early or late, radiation is an option, and I will break it down the line. And in certain cases, postoperative. In endometrium, stage 1B onwards, post-op plus minus brachytherapy. I will stick to cervix today only. Well, in stage 1A, radical brachytherapy alone can be a treatment, wherein, as I told you, that the incidence of nodal metastasis is so low in that case that giving a very, very high dose to the cervical area alone can be curative. In stage 1B and 2A, by this time, the pelvic nodal burden is significantly high enough so that you have to address them with radiation, and therefore external radiotherapy and brachytherapy is an option for radical treatment for cervical cancer. And though the outcomes are equal to surgery, generally it is preferred to offer surgery in these patients because the toxicity for external RT and brachytherapy alone is slightly higher, especially in a younger patient group compared to surgery alone, because it leaves no residual side effects in a good surgeon's hand. 1B2 is a very peculiar area where endocervical or barrel-shaped tumors are their area of controversy, because radiation response is somewhat poor in them because they have a lot of hypoxic areas inside the tumor. They don't respond well to radiation. On the other hand, surgery will almost always entail postoperative radiotherapy. So therefore, it's still an area of controversy. From stage 2B to 4A, external RT plus brachytherapy is the standard of care with no surgical alternative available for them. In 4B, where you have diseases which have gone into the nearby areas, it's only a palliative RT. Postoperatively, when do we give radiation? The indications for radiation in postoperative situation depends on the pathological features like deep stromal invasion. The size is more than 4 centimeter. If the parametrium are involved, if the cut margins are involved or close, and if the lymphovascular spaces are involved. Among this, usually the 1B2 is the one stage that we most of the time end up giving post-op radiotherapy. As I told you, it's actually worse to treat a 1B2 than to treat a stage 2 cervical cancer. Now, what sort of dosages we use? For a radical dose of external RT to the cervix, the whole pelvis receives 40 to 50 gray. Gray is a unit of radiation over a period of 5 weeks. And if the parametrium is involved, as it's in a case of a stage 3B or so, sometimes parametrial boost is necessary. And if it's a stage 3C where we have nodal involvements, the nodes can be boosted with IMRT to a dose of 60 to 66 gray or so equivalent. In a post-operative situation, 45 to 50 gray to the whole pelvis is given, and as I told you, they're treated daily, 5 days a week for approximately 5 weeks or so. What is the volume that we treat in radiation? Well, the uterus and the ligaments, or vagina, depending on how much is the vaginal involvement. If the vagina is involved, then you have to come down to the lower vagina as well. Common iliac nodes, internal iliac nodes, and the obturator nodes. As you can see, this classic diagram of the radiation volume in a cervical cancer patient is represented. This book is from 1950s. The fundamentals have still not changed. Back then, in the 60s and the 70s, the radiation volume was determined with the help of simple X-rays, wherein on the simulation films one would mark out the areas. Things have changed since, and we have now totally moved on to CT scan based planning. So what we do is to take a serial CT scan throughout the pelvis at very minimal depth intervals, and from that we reconstruct the entire human anatomy and determine how to give the radiation with the help of radiation beams which are shaped to the shape of the tumor, and leave out the areas which don't want to give radiation to. This is a typical case where we can, with the help of the CT scan, you can construct the patient in a 3-dimensional plane, and the radiation field essentially covers the path of the 2 major vessels along which the nodes are distributed, and the area where the cervical area is there. One of the major developments in radiation for the pelvis is use of intensity modulated radiation, because we have a clinical situation most of the times in these situations where the tumor is embedded, the tumor is surrounding a very sensitive structure, and if you want to give radiation to the whole thing in a conventional technique, you will end up giving radiation to the organs at risk as well. So by refining the techniques like 3-dimensional conformal radiation and further refining it to the point we slowly take the radiation area out of the organs at risk and focus only on the organ at risk. So these techniques are called intensity modulated radiation therapy, or IMRT. IMRT, though does not have any outcome benefit in terms of overall survival, can bring down the dose mainly to the bowel in cervical cancers, and thereby bring down the toxicities and complications that can arise out of small intestine exposure to radiation. This is an example of how IMRT can save the dose to the bladder versus a conventional technique where the whole bladder gets radiated. As I told you that I'll come back to brachytherapy because that is central to the treatment of cervical cancer. Now, cervix cancer, the trick about cervix cancer is to be able to achieve more than 100 gray inside the tumor. There is no other technique by which you can achieve it. Because if you are giving radiation from outside, by the time the dose reaches the central part of the body in the cervix, other parts of the body are going to get unacceptably high dose. Therefore, the trick is to insert a radiation dose inside the tumor and then let the tumor receive the maximum dose. And if you see, the tolerances of this cervix and the uterus is about 100 gray, upper vagina is 238 gray, and lower vagina is 98 gray, which are very, very high tolerances. And the rectum, bladder, intestine have much lower tolerances. You simply cannot achieve 100 gray radiation to the cervix without breaching the tolerances of the surrounding structures. Hence, brachytherapy. Now, brachytherapy works on what we call as the inverse square law, which basically tells you that if you are measuring a energy from its source, the flux of the energy is inverse to the square of the distance from the source, which means once you move away from the source, the radiation falls off rapidly. So if you insert the radiation source inside the uterus, inside the cervix, surrounding area of 1 or 2 centimeters is going to get very, very high dose. The next 3 and 4 centimeter, the dose will be very, very low where the rectum and the bladder lies. Therefore, one can deliver a very high dose to the cervix tumor per se without crossing the tolerance of the rectum and the bladder. When do you give radiation brachytherapy? Well, one should keep on assessing the response of the tumor, and if you are having a 5 weeks plan for radiation to the whole pelvis, by the time the tumor has shrunk enough to allow you a good geometry for application of the brachytherapy applicator, one can start, so that the total duration of the treatment is kept below 6 to 7 weeks. In fact, one can interdigitate the brachytherapy, as the radiation goes on, 4 days or 5 days of radiation, and the 6th day one can give the brachytherapy and finish up the whole treatment at the same time, especially for early cases. And there are multiple techniques in which the brachytherapy can be delivered: pre-loaded, after-loaded, manual. I'm not going into the details. There are multiple customized applicators available, which can be used to be able to access the cervix, and the radiation source goes right deep into it and delivers the dose there. In the past, we used to use simple X-rays to determine how the radiation is going to be distributed, and there were systems called so-called Manchester system, and so this is almost 70-80 years old techniques. However, these days we have moved on to image-based dosimetry, in which with the help of the images drawn on a MRI, we have MR compatible applicators. In our hospital, we have MR compatible applicators, in which the pre-existing disease MRI is superimposed on a CT scan with the applicator to determine the parametrium and the gross tumor and do a dose calculation, which gives a higher survival rate. The EMBRACE and the RETRO-EMBRACE trials have shown that once you use image-based dosimetry for brachytherapy, the survival rates can go up. This is an example of image-based dosimetry that we have done here. The dose distribution is shown on the CT scan. What is the role of chemotherapy? Well, chemotherapy is important in serious cervix. Traditionally speaking, it is given in a dose of 35 milligram per meter square, weekly infusion over 5 weeks. And it has shown, there are more than 10 randomized trials that have shown that there is anywhere between 5 to 9% improvement in survival, which is huge. And thousands of lives will be saved if you consider the number of patients who are diagnosed with serious cervix. The benefit is more in the earlier stages, but even in the stage 3, the benefit is not negligible. However, in Indian population, there could be a significant toxicity, and that must be something that one has to look out for. So, a little bit on the vaccines, just one slide, is that since it is a HPV related cancer, which is basically spread through communication through contact, it is important that we vaccinate our young children to bring down the rate of transmission in the community and use barrier contraceptives to stop the spread of HPV. And that is possibly more important than any surgical technique advancement or radiation technique advancement. Now, radiation to the pelvis is not without its side effects. One can have radiation cystitis, which is seen with brachytherapy most of the time, which could manifest as frequency hematuria, bladder frequency and hematuria, and they sometimes need bladder irrigation with glycerol or hemostatic agents like formaldehyde. When you cannot manage them with that, sometimes they need to be given cystoscopic cauterization. Similarly, radiation proctitis can also happen in cancer cervix patient, which is seen as tenesmus, spurious diarrhea, hematochezia. On scopy, one can find edematous mucosa, erythema, and ulcers, and most importantly, telangiectasias. These bleeding ulcers, telangiectic ulcers, are the classic hallmarks of radiation proctitis, and it is treated with laxatives, oral hemostatic medicines, steroid creams, retention enemas, and if nothing works, argon plasma laser coagulation is very, very helpful in bringing down the bleeding. And this is the same patient after, here you can see the radiation proctitis which was bleeding, and after the laser coagulation, the entire area has become blanched with a little bit of scarring but no bleeding. So with this, I will end my presentation. To summarize, CS cervix is a major killer of Indian women, and radiation is very, very important in almost all the stages of CS cervix, but more so in the late stages, as we see most of the stages patients in our country reported as. Thank you.
Cancer is actually reducing, and that is something which I think all oncologists have observed.
Yes.
Compared to where 20 years back we used to see a lot higher number of cervical cancers, and that seems to be coming down. One of the links is between poverty and hygiene. As poverty reduces and hygiene improves, we have seen across the world that the rates of cervical cancer actually decrease. So that's one explanation which we can think of. Just adding on a few lines about chemotherapy, aside from concurrent chemoradiation, when a patient relapses and cannot either be operated or cannot be offered a second course of radiation or brachytherapy, the only option remains chemotherapy. Unfortunately, the results have not been very good so far. With conventional chemotherapy, we expect response rates of around 30 to 40% and survivals of anywhere between 8 to 10 months. Most chemotherapy drugs don't really seem to work well in CS cervix. There was a brief hope when bevacizumab came in, but again the outcomes with bevacizumab are not great, and particularly the side effects including fistulas seem to be of a major concern. Some hope now that we have got immunotherapy which works better than chemotherapy in a certain subset of PD-L1 positive CS cervix, but again there is still a way to go. Probably the best treatment for cervical cancer is to ensure that you don't get cervical cancer, and that's through vaccination and regular screening. And with that, I would like to thank all the speakers for a wonderful session on cancer cervix and gynecological cancers. Thank you very much.
Thank you very much.